agreed to host us for this exceptional meeting, and our sincere thanks. I'd like at this time to introduce Ed Curtis, CEO and President, Memorial Health System. Mr. Curtis.
Thank you, Bob, and welcome to the Citizen Club this morning here. And we're so excited to host this event here at the Center for Learning and Innovation. This is a new, innovative facility that we've done in partnership with SIU School of Medicine. Today's speaker is going to share with you a lot about how this center is going to change the way we educate the next generation of physicians, nurses, and all allied health professionals. But it's a distinct privilege for me as CEO of Memorial to have the opportunity to introduce today's speaker. Today's speaker, Dr. Jerry Cruz, was born in Missouri, raised in Salisbury, Missouri, went to the University of Missouri for undergraduate, summa cum laude, and then got into medical school there, graduated summa cum laude from medical school, and then did his residency in family and community medicine there, and also along the way got a master's in public health from the University of Missouri. So Jerry is diehard Mizzou, born and raised. In 1984, when he finished his training, Dr. Cruz joined SIU School of Medicine and was involved in the Family and Community Medicine Department in Quincy, Illinois, where he worked for a number of years. Until 1997, he became chairman of the Department of Family and Community Medicine at the medical school with sites in Quincy, Carbondale, Springfield, and Decatur. And Jerry's been very instrumental in the growth of academic medicine in that department for a number of years. Jerry is a professor with tenure in the Department of Medical Education, professor with tenure in the Department of Family and Community Medicine. January of 2013 was named Executive Vice Dean of the Medical School, and then was named Chief Executive Officer of the SIU Healthcare, the practice plan of medicine at SIU. So you can see Jerry's got a lot going at SIU School of Medicine, and was recently named by the Board of Trustees at SIU to be our 4th Dean and Provost in the history of SIU School of Medicine, and he will take on that job as of approximately 2 months from today on January 1 of 2016. In addition, Dr. Cruz has been very involved nationally in academic medicine, and in 2007, then Secretary of Health and Human Services Michael Levitt appointed Jerry to the Council for Graduate Medical Education Board, a very prestigious board that sets policy around training of resident physicians. Jerry served on that board for a 4-year term. He recently was president of the American Society of Family Medicine Teachers in family medicine. 4,500 physicians around the country. That was a 3-year term that Jerry had. And today he has been appointed to the American Board of Family Medicine, one of 16 board members. So you can see Dr. Cruz is very involved in a lot at the national level, a lot at the medical school here. But I will tell you this about Dr. Cruz. I've had the privilege of working with Dr. Cruz since he became chairman around 1997. And the things that I've admired about Jerry is it's obvious that, as all physicians, very bright, very committed to the academic mission of the medical school. But one of the things about Jerry that I most admire is his humility. He's a man of great humility and cares deeply about patients and cares deeply about education and our students and our patients. And I think when you look at somebody that has a degree of kindness, willing to go the extra mile, shows empathy in all situations, and leads from a standpoint of humility, we're going to have a fantastic 4th Dean and Provost of SIU School of Medicine. So it's my privilege today to introduce Dr. Jerry Cruz.
Thank you, Ed. So thanks so much, Ed, and it is great to be here at the Memorial Center for Learning and Innovation, and thanks so much to the Citizens Club of Springfield for inviting me today. It's good to see so many citizens out here today. It's great. And thanks also to the Citizens Club for giving me this very focused topic to speak on, the future of healthcare. I was hoping you'd speak about the fate of the universe, but maybe next time. I don't know. So I think all of us know that in the past, particularly the past 2 decades, that American medicine has really faced unprecedented challenges. And those challenges have led to many changes in healthcare policy, the delivery of healthcare, and healthcare education. And I think all of us in healthcare education and the delivery of healthcare really recognize that those changes bring great opportunity for all of us and actually give communities, give organized health systems, educational institutions the opportunity to create the future for healthcare. And so today, I'm going to talk about creating that future, but I'm going to talk about the past a little bit, some of the things that have gone on, where we are at the moment, and then go into some future things as well. I'll talk about some things that have occurred nationally, some things that have happened here in the state of Illinois, and then specifically about things that are happening in the SIU School of Medicine and the institutions that sponsor at the SIU School of Medicine and are our partners as well. So first, I'll just say a word about me. As Ed said, I'm from central Missouri, Salisbury, a town of 2,000 people, 100 miles east of Kansas City. There's a gas station, a theater, a church, and that's my dad in 1930 with the chickens on the farm. He turned out to be a butcher, a grocery store manager, a general manager of a chain of grocery stores throughout his career. But here is my mom in 1950. She would not have believed anything Ed said about me. There's no doubt about that. But she graduated from high school in 1936. She was hired by the general practitioner of 33 years in town at that time, George W. Hawkins, who you see on the right. And up until 1952, for 16 years, she was his office staff. She was the receptionist, the nurse, the coder, the biller, the note card taker, which was the electronic medical record at that time. And Dr. Hawkins was a full-service general practitioner for sure. Here he is doing a home call house visit in 1953, just after he delivered me. And that's me right there. Yeah, and that's his wife, Eula Bell. She would accompany him on the home visits as well sometimes. Dr. Hawkins and Eula Bell liked to take the train to St. Louis for vacations. And when they did, they gave my mom the keys to the Model T, the nicest car in town, because the people needed their regular visits and their regular injections. Injections of penicillin, injections of cortisone, a steroid, injections of stelazine, an antipsychotic. Yep, she's got a lot of stories. She died December 23rd last year, and at the visitation, the most amazing thing was all of the people who came and told the stories from 1952 and before, 60 or more years before, they remembered the type of care and the type of practice that Dr. Hawkins had. It was pretty amazing, a presage for the future of what we want to do. So that's me when I'm age 2. As you see at the top, my mom wrote on there, Jerry preaching. She actually wanted me to be a minister, but she didn't know what I was preaching about there. Buffering. Can you see that? There it is, yeah. Oh, well. Okay, enough about me. Now, the SIU School of Medicine. The SIU School of Medicine is one of 194 medical schools that train physicians, either MDs or osteopathic physicians. We were the 103rd school founded. We're middle-aged now. We're a community-based medical school, which means we don't own a hospital. And quite frankly, with our partnering hospitals, Carbondale, Memorial, Blessing in Quincy, Memorial in Decatur, St. John's here, and Memorial here in Springfield, I think it actually gives us an advantage in many, many ways over the traditional type medical schools. Advantages to be really innovative. Here is a snapshot of who we are. We have about 800 learners at the School of Medicine. That includes 288 medical students, 325 resident physicians, physician assistant students, graduate students, 364 full-time faculty members, a lot of staff members, a lot of graduates. When you add them all up, we have about 3,000 people in the organization right now. We've had about 5,000 graduates. 2,000 of them are in Illinois. Now, most of those 2,000 are in those colored counties, the colors other than gray. And those are the counties that are the service area of SIU. That is the area to which we are accountable, to the 2.2 million people of those 67 counties in the southwest part of the state, western, central, and southern Illinois. The historic identity of the SIU School of Medicine is listed here in the blue. Are some issues that are related to innovation in education and curriculum delivery. Now, SIU has led the nation in innovations in education in medical schools since its birth in 1970. It was the first school to have problem-based learning. It was the first, or among the first, to have standardized patients, to have objective standardized clinical examinations, and to have a fully organized surgical skills lab. And you'll hear more about that as we move along. We also have been dedicated to our social accountability. You already heard that we're committed to a defined population in those colored counties there. But also as a measure of social accountability, the SIU School of Medicine has been a bright spot in American medicine for building a balanced physician workforce. Since the beginning at SIU, 45% of our graduates have become family physicians, general internists, or general pediatricians. Now that number has waned a little bit in recent years, but that's a record that virtually no other medical school can claim, and which every medical school should claim, but doesn't. Now, we've done really well in our educational systems. So the Liaison Commission on Medical Education accredits medical school. And it's good for medical schools to be accredited because then medical students can get into residencies then. Anyway, that accreditation comes about every 8 years. The last 2 times we were accredited were 2007 and this year, 2015. We got no citations from those visits either time. To our knowledge, we are the only U.S. medical school in history that has received consecutive 8-year accreditations with no citations. It's quite an accomplishment. Also, we've become involved with the international groups, most specifically the Association of Medical Educators of Europe, and that organization gives excellence awards in its 4 Aspire categories. And so in 2013, SIU got excellence in 3 Aspire categories that you see on the slides there: student assessment, student engagement, social accountability. The only medical school in the world that got excellent ratings in 3. We're going to go for the 4th one next time, faculty development. Okay, yeah. Our faculty group practice at SIU is called SIU Healthcare. The only thing I'll say about that is that it's growing, it's doing well, it's blending very well with the physician complement across the Springfield area and working well with our sponsoring hospitals. 254 full-time physicians and about another 50 part-time physicians. Now, there is significant need for innovation in education and in clinical practice, and there are a lot of reasons for that. Some things that we already see happening are shown in this slide. In the blue are things that are related to payment, and in the red are things that are related to a new philosophy, a new model of care. So as far as the payment goes, the traditional way in which health systems and doctors were paid, fee-for-service, is stagnating to some degree, changing. We're now up on the hook for penalties if our quality is not as high as it should be, or as how others define it. And also, we're getting more and more opportunity to improve our practice and get paid for good performance, for having high-quality measures, for coordinating care in a proper way, for actually taking risk with partners and sharing those savings that have come along that way. The other thing is when we turn to the red 2 points there, the way that physicians used to view taking care of patients was, well, we'll take good care of the people who come to see us. And we'd like a lot of people to come to see us. But the new philosophy is this: we're going to find the people who need care and offer it to them. It's a very different philosophy. And it's defined by care of populations and taking responsibility for health of defined populations and communities. So the United States was in a particularly bad time in 2008. This was pretty much the depth of where the U.S. healthcare system got as a whole. And, you know, I say that, I make it sound bad. You know, we were lagging behind many of the other industrialized nations in the world in a number of population-based categories. For example, in 2008, the United States spent more on health care than any other industrialized nation by far. The worst part about that is that gap had widened since the year 2000. It was not getting better. At that time, the access to care in the United States was the worst in the industrialized world, and that gap had widened since the year 2000. on virtually every quality indicator of population-based health outcomes, whether it was general or disease-specific, the United States trailed the rest of the industrialized world. And the bad news is the same. Since 2000, those gaps had widened. And the worst sector of U.S. healthcare performance at that time was the care of children and women of childbearing age. And guess what? That gap had widened since the year 2000. From 1998 to 2004, the number of medical students, physician assistant students, and nurse practitioner students, the percentage of those students who chose careers in primary care dropped by 50% over that 7-year period of time. That's a big drop for sure. And all of these things were going together to say, hey, there are big system changes that are needed in American healthcare. So I'm going to give you a couple of examples of these things in statistics you can understand. So you can break the United States population down into 3 segments. The elderly, people over age 65. Number 3, women of childbearing age and children. And number 2, everyone else. So if you just do percentile ranking with the rest of the industrialized nations, hey, care of the elderly, we're at 65th percentile. We're better than 2/3 of the rest of the world in our system of universal care for the elderly, Medicare. Everyone else, we're at 13th percentile, not so good. Women of childbearing age and children, below 1st percentile. Big gap between us and nation number 37 there. Nothing to be proud about for our country, quite frankly. A lot of it related to access, a lot of it related to culture, a lot of it related to the balance of the physician workforce. And, there's just a lot of factors that go in there. It's just not good, though. Now, here's a demographic factor that's going to feed in and make things difficult for moving forward. This is a challenge that we're going to meet, I would say. But this is the ratio of the full-time equivalent workers to the number of Medicare beneficiaries. And this is from David Walker of the Government Accountability Office. He presented this to us at COGME, the body that Ed Curtis mentioned earlier there. As you see, if you draw some lines here, that from 1960 to, well, actually, quite frankly, from World War II all the way up to the year 2000, 2005, that ratio had been stable at about 4:1. As you see, from 2040 on, that ratio is going to be stable at 2:1. But you got to get from 4 to 2. You got to get from 4 to 2. And so we are right at the start of the blue bar there, that 40% decline in that ratio that occurs from 2010 to 2040. So this payment demographic, this age demographic will color all that we do moving forward as we develop new healthcare educational systems, healthcare policy. All right, we got a problem in the United States, but it's related to Jason Kidd here, the NBA All-Star point guard. Upon his trade from the New Jersey Nets to the Dallas Mavericks, he said this: we're going to turn this team around 360 degrees. Yeah, we had a lot of work to do there for sure. Okay, in 2007, the Institute for Healthcare Improvement put out its triple aim, which we've moved to a triple aim +1 right now. So all of the policies that we work on a macro level are related to this triple aim: effective, efficient, equitable, and enjoyable health care. So improve population-based health care outcomes, reduce per capita cost of care, access for all, and great patient experience, great provider experience. Those things all have to happen. And actually, on that blue one, number 4, I'll just tell you that SIU School of Medicine has learned a lot from Memorial Health System for sure. All right, now, President Obama is elected. Here are his principles of healthcare reform for the Affordable Care Act. The philosophy was more one of collective responsibility rather than individual responsibility. His private insurance philosophy was public accountability of private insurance companies. And you know what that meant is that a thing called the medical loss ratio had to be set at a certain level. It was a kind of regulatory control that actually hasn't been fully implemented yet for the ACA. Very important as we go forward. I'll mention it again in a bit. For Medicaid and mandated insurance, mandated coverage for all children, expansion of Medicaid, national health insurance exchanges. That's occurred to a large degree. The only one that hasn't is that some states have chosen not to expand Medicaid. The clinical emphasis was a lot of money for electronic records, which is now translated into meaningful use dollars, which are actually coming, and an emphasis on primary care, preventive medicine, and public health. President Obama wanted a National Institute for Quality. That didn't happen. He wanted a National Workforce Institute, actually to take a step above COGME, the group I was on. That hasn't happened either. That one's authorized. It just hasn't been appropriated yet. So, as we look at these things going forward and as these changes start, there are some facts about health care that are the most important ones for system reform that sometimes are very difficult to understand. And I've listed a few on here. Most people might not come up with these initially, but a balanced physician workforce, the effectiveness of primary care, the simplicity of better outcomes at a lower cost, and that health care reform is working already on a lot of realms. Okay, why is it hard to understand? I don't know. Mike Ditka was a pretty good philosopher, though. So when he was asked about the effectiveness of surgery for his eccentric quarterback, Jim McMahon, he said this: the shoulder surgery was a success. The lobotomy failed. So, a lot of times we're not all going to see eye to eye, and as we move forward on health care reform, we got to understand where other people are coming from. So, one of the best healthcare policy researchers and healthcare workforce researchers ever in the world was Barbara Starfield at the Johns Hopkins Bloomberg School of Public Health. And in 2005, she synthesized all of the world's literature about effective healthcare systems and what were the most important factors to move a system toward better population outcomes, lower per capita cost, and better access for everyone. And these were the characteristics: a true regional assessment of healthcare needs and allocation of resources based on that assessment, universal access to care guaranteed by a publicly accountable body. That certainly does not say socialized medicine. It just said a publicly accountable body must ensure that there's universal access to care. The third one is interesting: low or no copay for primary care services. Actually, in high-functioning healthcare systems, there's virtually no out-of-pocket expense for primary care or catastrophes. Real emergency type visits, as a matter of fact. The other things relate to a balanced physician workforce and the things that get to a balanced physician workforce. Number 5, 40 to 50% of all physicians being primary care physicians. So remember that number, because actually I'll show you in just a minute where we are. The national organization COGME, after I left COGME, actually wrote a letter to Congress listing the specialties in the United States that are in absolute shortage. And they're listed here: family medicine, general internal medicine, geriatrics, general surgery, psychiatry, and the subspecialties of pediatrics in short supply. COGME also noted that there were many other specialties that had dramatic and really bad geographic maldistribution. So there are shortages of other types of physicians in many areas in the United States, but it's because there are excesses in other places that haven't been moved across the geography. Specialties in shortage in our region, well, we get some idea because we know which doctors are where. I think we probably need a better scientific analysis of this. And so in our strategic plan at the School of Medicine, number 1.2 is to develop a workforce plan driven by population-based healthcare outcomes, societal need, analysis of local and national needs, and the opinions of our partners, which are healthcare systems, hospitals, practicing physicians, communities, the people, patients. Those are our partners in making this analysis. And I think we as a school will need to help spur that analysis on for this area. All right, now just a word about what's happened to primary care. This is kind of a stark graph that you see here. From 1979 all the way until until 2002, 36% of our workforce was primary care physicians. Actually, when you take a look at these lines here, it was pretty flat at 36 for almost 30 years. Then, again, from 1998 to 2004, a dramatic decline, and then a leveling at about 16%, after that period of time. So what's happening now is that we are having a drop of that 36% by 1% every 2 years. You know, that's the mathematics of all of this, and that's going to occur as long as that red line to the right is flat. We have just dropped below 30% in 2015. So again, when you think about that aging population slide you saw and this one, some drastic policy measures are going to be needed, or we're going to need some drastic changes in the way that we deliver care and the way that the variety of healthcare professionals practice. Something that we call practicing at the top of their capabilities, practicing at the top of their license, and that kind of concept. Okay, now an example from Illinois of a very simple way to solve a problem. So this is Illinois Medicaid, and this is two programs that were developed in 2006, Illinois Health Connect and Your Healthcare Plus. So Illinois Health Connect was a simple medical home project. Medicaid asked every general internist, general pediatrician, and family physician, will you take more Medicaid patients in your medical home? Now, that was the definition of a medical home. You are one, as a matter of fact. If so, how many? Then they got a list and asked the Medicaid patients, would you please pick a medical home? Right? And here they are. And then they paid the medical home $3 per member per month to be in that medical home. And the medical home was also eligible for $4 per member per month if they met quality standards. Okay, that's one program. The second program, Your Healthcare Plus, was identifying high-risk, high-utilization, highly vulnerable patients using a nurse analysis and intervention and then getting the patient into a practice and seeing what happened with that. The state of Illinois contracted with a private company, McKesson, to do this. This was the response. 5,700 medical home practices responded that they could take 5.4 million people. Well, there are only 2.7 million Medicaid patients in the state of Illinois, so the capacity was there. The Medicaid patients, 75% said, I will sign up. 2 million total. Overall, over the life of the program, very high satisfaction. Now, this is a slide, some of it's a little hard to see, but the red bar that goes up linearly is the projected cost of the high-risk, high-cost patients in the Your Healthcare Plus program. The blue line is the real costs. You know, starting in 2006, you see the significant savings that were attained there. A lot of that was because of a decrease in emergency room visits and a dramatic decline in hospital visits. And actually, in every system of this has been done across many states. I mean, maybe hundreds of times by now. And this is what everybody sees when the care is coordinated like that. A dramatic drop in the first year, a little bit more drop in the second year, and then a little raise and a flattening as we go out. What happened to the quality measures? Dramatic improvement in the quality measures with this very simple intervention. Many of them threefold above what they were before at a lower cost. More tests at a lower cost. Ooh. Anyway, the savings to the state of Illinois, as calculated by the Commonwealth Fund, reached $250 million for Illinois Health Connect and $500 million for Your Healthcare Plus in the year 2010. Unfortunately, Your Healthcare Plus doesn't exist anymore, and other systems have come in to try to replace it. Anyway, it was a very simple program with really resounding results. So this concept about healthcare reform working. Here are the things that have happened recently. The percentage of Americans who have health insurance has risen from 83 to 91% since 2014. Now, we say you have universal coverage when you reach 95%. And that's the maximum the U.S. can reach under the current system because undocumented workers are not included in the system, and that's about 5%. So the healthcare spending, this is an amazing one. So when we were at COGME, the CIA came in, you know, and they said that national security would be threatened if the percentage of GDP spent on healthcare exceeded 20%, because we'd have less for defense, less for transportation, less for education, less for social programs, right? And they were really worried about that because the rise was inexorable. Well, for 5 years, it's been at 17.4%, with just in the last 3 months, a little blip upward. So that's going well. Medicare per capita cost, readmission rates, admission rates, age-adjusted mortality have all decreased since 2008. Actually, they were on the decline a little bit from the year 2000 to 2008, and then actually took a boost up there. Healthcare, rolling 5-year healthcare prices are up 1.6, the lowest in the 50-year recorded history. So these are some indicators that show some things are starting to move in the right direction now, and they're giving us, some real chances for big opportunities, I'd say. All right, Tim McCarver, all-star catcher and Fox broadcaster, said this about his battery mate and Hall of Famer Bob Gibson. He's the luckiest pitcher I ever saw. He always pitches when the other team doesn't score any runs. Was Bob Gibson lucky? No. Bob Gibson created the future with hard work and teamwork. And so that's what we're going to move into right now, is creating the future. I'll talk about care coordination for just a minute. Our philosophy at SIU is that 3 types of care coordination are the foundation of care coordination and need to be done first if possible. That's the development of registries, the development of programs for high utilization, highly vulnerable patients, and programs for the transition of care. Those things allow the development of other care coordination programs. Actually, the other types of care coordination, which are shown in red, are easier to do. It is easier to identify a specific disease and coordinate that care, and it's a little bit easier from a community level to help people navigate through the system. All of these things are important and are related, but we really are trying to make sure that, I would say this, that as a community and as a region here in Springfield, that we're getting these types of care coordination done. Now, I'll give you an example from Memorial Health System here. We had many conversations about the philosophy of care coordination. Jay Rosehart and his group here actually developed a plan and implemented it in 20,000 insured patients for which the system was taking risk. 1,550, and actually it's now up to 1,700 high-risk patients were identified. I think half of them were asked to enroll, and 400 did. These patients, actually, their cost to the system was almost $30,000 a year. That's really high cost. After the first 12 months, the cost for those patients was down by $1,200 per person per month. The first year savings, which would be reflected by the green bar in the middle there, was almost $3 million. And what was the intervention? The intervention was a nurse contacting the patient, doing a 90 to 120-minute intervention, writing a plan, delivering that to the healthcare provider, and checking on it periodically. I think that was it, right, Ed? I don't think there was much more to it than that. And it's just the simplicity of and elegance of really high-impact systems. All right. So now I'm going to talk about what we're doing with our various partners, and I'm going to focus on Springfield because this is the Citizens Club of Springfield. Just recognize that we're doing a lot of things all over the rest of the state as well, but we'll concentrate on Springfield. So one thing that goes hand in hand now, the new educational model, is that education and quality assessment and quality improvement are really moving forward together. And that's a vision that Memorial has, and that's a vision that we have. So in that realm, we are moving forward with population science and community engagement at SIU and hope to develop a program that will feed the kind of denominator information that's needed for these programs to really flourish. We're focusing on new methods of continuing professional education that raises the quality throughout a career. We're talking about new models of interprofessional education where healthcare professional students of all disciplines practice in exemplary practices where there are healthcare professionals and attendings of all healthcare professions. We're also trying to have a system where interprofessional cooperation on quality improvement measures and projects is something that's important as well. So, these are the kind of things that are the new type of education that has to happen. We've made some investments in telemedicine and community outreach. Those are the new technologies that we need for virtual types of care, both synchronous and asynchronous, and for consultations and for visits with patients. On the quality realm, two corporations have come up here that move this forward that are jointly owned by Memorial and SIU School of Medicine, the Midwest Healthcare Quality Alliance and the Quality Alliance Patient Safety Organization. All kinds of great things going on there. And then, of course, the facility and the philosophy that's embodied in the facility that's needed to move all these things forward so that they are optimized, and they're at the top of their capacity. The very building that you're sitting in here today, the Memorial Center for Learning and Innovation. Now, whoops. Oh, can I go back? There we go. So there might be one or two other places in the country that unite these type of functions in one place like it's done here. Maybe not. But the quality function is up on the 4th floor. The continuing education function is on 4th floor and is permeated throughout all the lecture halls and everything else that occurs here. The standardized patients and professional development occur on the 4th floor. The simulation center is the entire 3rd floor and is amazing. It's every simulation that you can imagine at a high technology level. And then the surgical skills center is on the 4th floor as well. So here, our students, our residents, Memorial's learners from other places are coming to get involved with the new technology and to master it either before they ever see a patient or as they hone their skills while seeing patients. When new technology comes, it needs to be mastered. This is the way that it's done. So anyway, I'm going to show you a little video here in just a minute. So this one occurs in the Roland Foe Surgical Skills Center on 4th floor here. And this one is an emergency cesarean section. That is a mannequin. That's not a real person. That's a model. We used a beach ball for a uterus and water for the amniotic fluid. But this woman is in cardiac arrest, and it's imperative that the operators get the baby out within 90 seconds in order to save the baby's life and to optimize the mother's chance to be alive. So two big incisions are going to be made. The first one that you saw right through the abdominal wall there from the belly button to the pubis. It's pulled aside, and there's the beach ball uterus. And there's going to be a couple little snips, one at the top, one down at the bottom, and then a bandage scissor is going to go up under the uterus, away from the baby to protect the baby, and snip the uterus all the way up. Again, doing this as rapidly as possible while you see the cardiopulmonary resuscitation going on for the mother there. So the operator gets the baby's head, pulls out the occiput posterior baby, and bingo, there you are in 90 seconds. Now, I'll just say this. I've delivered 1,900 babies. I've been in that situation one time in my training or practice. And this is of incredible value to our emergency physicians, our family physicians, our OBGYN residents who deliver babies, to experience that pressure situation and that time-limited situation and to practice that should that rare event occur to save 2 lives. Really amazing stuff. And there are cadavers up there, there are other models, there's standardized patients. It's just an amazing deal. So clinical initiatives with Memorial include these. I won't say too much about these, but we're working on these. Cardiovascular Services, Neuroscience Institute. We're actually really working on trauma from a quality and academic standpoint. We've formed physician groups like the Physician Health Association of Illinois, Memorial's primary care physicians, and ours. The Center for Family Medicine is a federally qualified health center with an organizational structure like virtually almost none other in the United States that's rapidly expanding and caring for those people that are most vulnerable. In the green systems, we're focusing on telehealth, e-care, virtual medicine, facilities, medical office buildings. With St. John's Hospital, the Children's Hospital, the Regional Perinatal Center, the Neonatology and Maternal Fetal Medicine are areas of excellence and are our focus with St. John's. We're moving forward with the Women and Children Center, a high-risk service for comprehensive care of women and children. Again, where you see we have a lot of strides to make in this area as well as the United States and facilities as well. And not only that, we are working with other physician groups in the area, something that is drastically important if we're going to meet the challenges of health healthcare of the future for a variety of things. Most of these things are with Springfield Clinic Memorial and SIU together. I'll just say a word about the bottom one. Allscripts, TouchWorks, electronic medical record. About 4 weeks ago, we took the plunge and switched completely to TouchWorks, and that means that Springfield Clinic, Memorial Physician Services, and SIU Healthcare are all on the same electronic medical record. That is a big plus for information sharing and better patient care. Okay, St. Louis Globe Democrat 1919, quote, after a gutsy performance by St. Louis Brown pitcher, Alan Sutton Southerton pitched his initials off today. All that means is work hard, right? Okay. All right. So at SIU School of Medicine, we're working with our partners in the realm of clinical education and quality improvement to change the culture, create the future, and work hard together. So, I'll say that, there's probably a lot more detail to healthcare of the future, but I think we've left a little time for questions here. So thank you so much for your attention, and it's been my pleasure to address you today. We can take some questions, right? If you like. Sure. Sure.
What do you see as far as comparison, like the Mid-Illinois Medical District and how it plays a role with the medical community here?
Well, the Mid-Illinois Medical District, it's a defined geographic location for services, for sure. And so I would just say that as we go forward, uniting the functions and having multiple organizations working together to do that is going to be, very, very important. Now, a lot of times little programs develop here and there. I think what you're seeing, in the past 5 to 10 years is probably a better planning process with more organizations coming together to do that. I think it's a really great concept that needs to flesh out. Yes?
Why do you think people aren't going into general practice as much, and what's being done to change that?
Okay, well, why do you think the students are not going into general practice or generalism as much? Actually, it's a very good question, because it's not only primary care. The number of general obstetricians we're training, general surgeons, general urologists, general orthopedists, those are all dwindling as well. It seems as if the term general is in the name, it's headed down. Now, I've done a lot of work on this, as a matter of fact, and I've written a couple papers, so you can actually Google me on this topic if you want to. But there's probably 4 major areas here, okay? Now, one is the pipeline of students that we get into medical school, and that is based on a lot of demographic information. I won't go into the details on that, but once again, recruiting those types of students who will more usually gravitate that way is probably something that we need to do, and in some ways we've gotten a little bit away from over the past 20 years. The second one is the culture of their education that they get, particularly in medical school. What happens there to support an outcome that leads to a more balanced workforce. I will just say that medical schools and other healthcare professional schools have really not had the incentives that they have needed to move toward that. There have been actually more incentives, and I mean financial and accreditation incentives. So that's how medical schools survive, by, they have to make sure that they have enough money, and they have to make sure they're accredited first, right? And so when the accreditation pressure and the financial pressure is for more specialization, that's what naturally happens. And that's what has happened in the United States. I've actually called for a summit of all of the accrediting bodies, all the way up from the MCAT examination to the licensing examination to the medical school and residency accrediting bodies, to come together and develop some kind of common vision for this, as a matter of fact. Then, another one has to do with the income. The income ratio is very vast when you compare primary care physicians to specialty physicians, and is the one that just causes some herd behavior in the other way. And then the last one is the blue one on that triple aim slide, enjoyment. For primary care practices, when you need to see so many patients and there is so much pressure for the paperwork and the other regulatory things that have to occur, and the production levels are so high and you don't get paid for care coordination, that enjoyment is not real high. Now, I will tell you this, though. This is the funny thing. That's kind of theoretical. When you get out in the field with primary care physicians, there's actually a much greater level of enjoyment than I think most people would predict. But, focusing on those four things are the things that would make a difference. And I think, well, if it's just my opinion, the income ratio is the one that is probably the most dominant factor and has the biggest impact on this. Back.
Hi, I'm Brooke, and I used to be a genetic counselor working here locally and then in Peoria. And I was just curious how you feel about this center compared to the Jump Training Center that's located in Peoria, if you guys worked at all with them and kind of developing this center, and how you feel that we'll be able to compete with maybe the Children's Hospital of Illinois and the medical program there now that we have this new facility. Okay,
the question was about this center, the MCLI, and the Innovation Center at the University of Illinois at Peoria. Well, I'm sorry to say I don't know much about the one in Peoria. I know that it's a nice big new building. Actually, it came online a little bit before this one, I believe. And so, here's kind of the root of this question. So, when we think about moving forward in healthcare, if you compete at the micro level, you're probably not going to move very far. You kind of have to have partnerships and move forward together in small levels. Now, what is that optimal level? Is the level here Springfield? Is it Springfield and the collar counties? Is it all of central Illinois? Is it the band from Quincy all the way through Danville, right through the center? Is it SIU's area? There's a lot of forces that are working here and a lot of market forces that are in play. And I think, some study is going to have to be done to see, what level of collaboration for both these educational things and the practice thing is going to have to occur. I mean, I would hope there would be some level of collaboration about new ideas that are generated so that we're not always reinventing the wheel, And they are fairly close centers. But I don't know if anybody else knows anything more about Ed. Would you like to say something there?
Comment. We're very impressed with the OSF system in Peoria. And Kevin Shepline, the CEO there, invited us up. And so our team with the medical school spent quite a bit of time working with them. And they pointed out things that if they had it to do over, they would do differently. They had some challenges around the high-end technology and said, here's how we resolved it. So we used the company they used to resolve it. So we did a lot in terms of learning, but we went from New York to San Francisco and everywhere in between, and not just in healthcare. So even casinos to learn how to do the conferencing space. So a full continuum of service, but the OSF people have been very supportive and helpful in working with us because we don't see we're competing in this particular domain, we're collaborating. But I'll say one last thing, and this is a credit to SIU. The SIU Surgical Skills Center that's on the 4th floor is probably the most developed center in the United States and including North America. It was the first of its center in kind. So the curriculum is so well developed, we'll have fellows from major places like Harvard Medical School and the Mayo Clinic send somebody here to learn, because it's not just about building the building and equipping the room, it's about the level of curriculum that you've developed around surgical skills, clinical simulation, some of the professional development, what the School of Medicine has done with the Midwest Healthcare Quality Alliance. So we're really investing in people, and then when we had solid programs, we constructed a facility, and I think we're quite a bit ahead of everybody in the country in this domain.
Thanks. Yes.
I noticed your video on a human simulator, and that technology has been growing all the time, last decade probably. Is there any other technologies on the horizon that might have a huge impact on what you're doing?
Well, I mean,
simulator is one, I think.
Sure. I mean, the question is are there technologies beyond the simulator that you see here? Well, we already have things that are well beyond that. That's a pretty simplistic one, as a matter of fact. Some of the mannequins and the simulations that occur in the simulation center on the 3rd floor, in the operating room bays and in the trauma center, they are using technologies that are really, that design the art. There's no question about that. I think that here at the MCLI, they've drawn from not only medical care companies, but companies like Disney and others to really, bring these technologies forward. I think, probably a tour of what's going on here would be a really good thing. And as you know, every day there's going to be, some new technology that will be incorporated here. But I will say that I'm just confident that the highest level of the newest technology is here. And, yeah. Any other questions? Okay.
My name is Jay Cook. I'm the Director of Education for HCI Alternatives. It's the medical marijuana dispensary that's opening up in Springfield, Collinsville. SIU has a policy that their physicians can't certify their patients for cannabis use. Could you explain that a little bit to me and what I can tell the community whenever they call about having an SIU physician and where they should go to be certified?
Right. So actually, we clearly want all of our patients to have the best care and to have, every modality available to them that they can. Here is the risk here. So, we've told our physicians that it's very risky at this point, to prescribe medical marijuana because it's a Category 1 drug on their DEA license, even though it's legal in the state of Illinois. And we don't want to put our organization or them at risk, so we have advised them not to prescribe it because it's Category 1.
What kind of risk do you think that exposes SIU to?
Well, I mean, those are types of drugs that we can't prescribe on our federal DEA license. And so, you can think of almost any scenario in malpractice that might be a risk there, or a regulatory risk, or a risk with the patient. It's just too much when the federal DEA is still the way that it is.
Should I tell SIU patients that have an SIU physician, should they seek care elsewhere?
Well, I suppose if someone is prescribing that and they want it, they certainly can get it in other places. It is legal to prescribe.
Thank you.
100 primary care physicians. Because of the DEA situation, we're exactly where the medical school on this. We are not going to put them at risk with their DEA license. So same answer for Memorial, and I'm perfectly fine if you want to tell them to go somewhere else.
Yes.
I'd like to know if you care to comment on maybe the 5 or 10 year outlook on healthcare coverage in general. You showed where it went from 83% to 91%, 95% is full coverage, and you look at that in relation to GDP at 17.4% being flat for the last 5 years. Do you see that GDP going down in healthcare in general nationwide, while at the same time the coverage goes up closer to 95% in the next 5 to 10 years?
I'm glad you asked that, because now I can talk about the fate of the universe. Yeah, so, let's see, what was the first part of your question again?
Well, full health coverage, 95%. Went from 83.
Yeah.
Your slide said 83. We're at 91 now.
Right.
95 is full coverage.
Right.
You see that happening in the next 5 to 10?
Well, yeah. So we have 31 million uninsured now. We had 50 million uninsured on January 1st, 2014, right? And so full coverage is 15 million uninsured. Yep. So we got 16 million to go. So one big thing is there are a bunch of states who didn't take the Medicaid expansion. So those people won't be covered unless they buy out of an exchange, and they may not have enough money for that. So that is probably 2/3 of that gap. The other third in the gap are people who are eligible for the exchange, the marketplace, and they continue to sign up. And so I think there will be some movement toward that, but we won't get to the 95% until all of the states accept the Medicaid expansion, right? Yeah, so, 31 million is a lot better than 50 million for sure. At SIU Healthcare, since January 1st, 2014, we have seen more than 80% decline in our charity care, more than 80% decline in our bad debt. And so, you heard the news reports a few months ago that like 67 percent of the people without insurance had signed up for insurance in the Springfield area. We've seen an even greater impact than that at SIU. Now, I don't know what's going to happen with healthcare GDP. You know, there are some forces that have occurred just recently that are moving it up a little bit. Now 1 out of every 10 Americans in the workforce is employed in healthcare. That is way up. You know, this is a really, really big industry. I think, you know, most healthcare policy experts would say that we would be most robust on an international scene as an economy if the percentage we spent was 12 to 14. So, you know, that would be the goal, would be to get to that point. That will not happen anytime soon, you know, for sure. And the question will be, you know, what will happen as the population ages. The good indicator there is all those Medicare indicators that you saw were getting better, you know, over the past 14 years, and actually really better over the past 7 years. So, you know, the thing is it's not even remotely as dire as it was 7 years ago. I mean, it's flattened off. It may fluctuate up and down. People are watching it very closely. We're getting more efficient systems of care, and I don't think anybody is really wanting for care more than they did before. Quite the contrary. I think more people are getting care. That's probably why the cost is lower. Amazingly enough, you know, at Access Health Adams County in Quincy, they got a federal grant some number of years ago to provide health care for people who didn't have insurance. 800 people enrolled, and a requirement of the federal program was for it to be analyzed by the feds, who came and analyzed it. So those 800, 1 year after they had received the care that they never had before, their cost to the system on average was $2,000 less per person for getting care, okay? So, I mean, these things are kind of mystical and magical to some degree, but, you know, taking care of the population is a pretty important thing to do, you know, just from, well, I don't know where the GDP is going to go, but I don't think it's going to do anything bad soon. I mean, the healthcare part.
One more comment from Mr. Curtis, and then we'll end it.
I was just going to welcome anybody that has time this morning. We're prepared to give a brief tour of the simulation facility on the 3rd floor, and our staff is here from SIU that run the Surgical Skills Center, so if anybody has time or interest, you're welcome to see some of the simulated areas available here today. And I think you can see from our presentation from our incoming Dean and Provost that the future of the medical school is very strong, and we're in great hands under the leadership of Dr. Jerry Cruz. Thank you, Bob.
Thanks so much. Thank you.
Thank you for joining us this morning.